innovation conference. We're here to talk about innovation. We're also here to talk about how we innovate and carry our center forward, carry our values, carry our eye on, ultimately, transformation and recovery. So, why FoRSE? The Foundation for Recovery Science and Education was launched by our organization in April of 2020. Does anybody remember April of 2020? Welcome aboard, Dr. Annie Peters. Yes, we worked for years to get to the point where we would be able to launch this program. We did a pilot program before that with Jessica Swan, and Omni Research were the researchers and the publishers of our first outcomes pilot, which proved the concept that we could do this. And what's this? This is a national, collaborative, large-scale outcomes data and analysis collection program that has never been done. And the reason it's never been done, well, I don't know. Among the reasons that it's never been done is it's really hard. It is a big, big project. But 4 years in, we are successful. And he's going to talk to you about the hundreds of treatment centers that are sending in data, the hundreds of thousands of pieces of individual patient episodes that we're able to analyze, and the reports that we're already producing, including the second annual report, the 2024 report, which we're very pleased with, and the other products that come along with it. But let me say this: if you can't measure it, you can't prove it, and if you can't prove it, you can't implement it, and if you can't implement it, you can't get paid for it. If you can't prove it, you can't do it. And that's the point of all of this. And if we do it, and we continue to do it the way we are doing it, we will take our seat as substance use disorder providers. We will take our rightful place at the seat of healthcare. And that is the goal. Tell my mom I'll call her back. Okay, so I think that's all I wanted to say, except that I'm going to introduce our superstar, Dr. Annie Peters. I've known Annie for many, many years. I brought her to Harmony Treatment Center many years ago to do a co-occurring assessment for us, and that started our professional relationship, and it led to our hiring of Annie, as I said, in March and April of 2020. She is the Director of Research and Education, but she is specifically the Executive Director of our Foundation for Recovery Science and Education. She is brilliant, she is hardworking, she's everything that a leader needs to be to lead this program. And so please give her a warm welcome, Annie Peters.
Thank you so much, Marvin. Is anyone still fangirling from the women's breakfast? Someone said, is anyone in here fangirling? And there were two of us in the back, because we were looking out at this wonderful array of women leaders, and now I get to look at all of you, and I'm so excited, because what I'm talking about is a representation of the work that we do that I'm really proud of. We are a unicorn. There is a unicorn here on purpose. This is the FoRSE horse, but he is not any regular horse. He's an actual unicorn, because that's what FoRSE is, although it exists, unlike most unicorns. I just want to start by saying I'm really grateful for this. I'm grateful that I'm co-presenting today with Dr. Nick Hayes, who is from Cumberland Heights and is an amazing scientist, and so excited to be partnering with him to talk about this. So exciting to be part of NAATP, NAATP, as you will, and just really excited to be here. So I am grateful as well, because I am a person in long-term recovery, and I am a product of treatment. I not only worked at Harmony Foundation, I went to Harmony Foundation 20 years ago. I have 20 years. Thank you, Harmony. Yes, thank you. That's amazing. And I say that because we've long relied on telling our stories to demonstrate what we do, that what we do works. And it's great to stand up here and to say that to you. But we also know that we need to tell that story in numbers and data to tell the world, because our stories are the most meaningful pieces we have, but we absolutely have to rely on our data to tell the story as well. So that's why I'm here to talk to you about that today. So as Marvin mentioned, FoRSE is, if you're not familiar with FoRSE, FoRSE is NAATP's Recovery Research Foundation that we developed in 2020 to help addiction treatment and recovery support providers to examine and communicate the value of the work that we do. As was said on the first night, this organization represents the short list of providers who are committed to ethics, committed to quality, committed to providing an essential form of healthcare that isn't often recognized as such. Just going to start with this. For most of the time I've been working in the field, we've quoted 1 in 10, that 1 in 10 people in the country struggle with a substance use disorder. This is from SAMHSA, their most recent national report. It's now estimated at 1 in 6. 1 in 6 people in this country who meet criteria for a substance use disorder. So the 1 in 10 number is now alcohol. 1 in 10 people meet criteria for an alcohol use disorder. 1 in almost 10 people meet criteria for a drug use disorder. 1 in 6, almost 20% of people age 12 or older have had a substance use disorder in the past year, and that's why we're all here today. This is from the NAATP website. 85% that don't get the help they need. Unimaginable with a chronic illness, that 85% of those 1 in 6 people don't get the help they need. That 380 people die every day due to alcohol. There's a drug overdose death that occurs every 5 minutes. Unconscionable, unbelievable is the crisis that we have in front of us. And why? Why don't people get treatment? So on the left is from that same SAMHSA report. Why do people themselves say they don't get treatment? The first one, 78% of them said thinking that they should have been able to handle the alcohol or drug use on their own. You don't hear that about cancer or diabetes or health disease. Well, I thought I could handle, maybe sometimes you do, but not as much. I thought I could handle it on my own. What that speaks to is stigma. Not knowing where or how to get treatment, more than half of them. Thinking that treatment will cost too much or not having health insurance coverage, unbelievable for this level of problem that we have. Lack of parity, they can't afford it. Racial inequity, we know that about the same amount of black and white individuals have substance use disorders, and yet the overdose rate among African Americans is double, with Native Americans, American Indian, Alaska Native population, it's triple, and that is due to racial inequities. We know that there's lack of research. Does anyone know when, I'm sure a lot of you do, but when did the American Medical Association say that addiction, not just alcoholism, but addiction was a disease? You'd think 1850 or something, you'd think? No. 1987. So how many people were here in 1987 alive? Okay, yeah. We remember, I remember 1987. Unbelievable that was when addiction was considered an illness by the American Medical Association, considered a chronic illness, a chronic disease. So the fundamental issue is addiction healthcare hasn't been historically treated the same as the rest of healthcare. So we have to change that. We need research to do that. As Dr. Hayes says, research is the language that payers and policymakers understand, and even the public. When we see statistics and they're legitimate statistics, hopefully we can trust those, and we need that research to be happening, and it's not primarily because of stigma. So I stuck this in there. The creation of FoRSE is undoubtedly the keystone to our future. Our future ability to advocate for our programs will be entirely grounded in data. So today is Science Day, and that's a good thing. And we need to do, a lot of us look at what we can do in our own organizations to demonstrate our effectiveness. And Nick's going to talk about that when he gets up. What he does with data in his organization is really exciting and is inspiring. So he'll be talking after me, but I'm going to be talking bigger picture, because what we can do together, if you think about it, how many people in this room represent a FoRSE data site that submits data to FoRSE? Look at this. Unbelievable. Thank you. You are the horn of the unicorn. So that's why this is so different, because we're a nonprofit organization that developed a nonprofit research foundation to say that what we can do, thank you, yes, she's putting up her unicorn, that what we can do together is so powerful, because we can take the messages of the data that we're finding and the research that we're doing, we can take this message to the world together in a way that we can't do with just program by program by program. So, so that's what FoRSE is. We created the framework for us to do this work together. And we tried to create it to be as simple, as cost-effective. It's currently been all free, and created it for you and by you. We created it because treatment providers said, we need help with this. We need help demonstrating the effectiveness of our programs. I love when John Curtis on the first night from the retreat with his Career Achievement Award said they've been doing outcome studies for 17 years because we wanted to know what we're doing is working. That's what we want to know, right? We want to know what's the impact of our programs. I want to jump into the report. I'm really excited about the report, but I wanted to give a little bit of context. If you don't know what FoRSE is, I'm just going to briefly describe it for you. This is how FoRSE works. This is the framework that we have to do this work together. And this is different because it is driven by treatment providers. It's not driven by the government. It's not driven by a profit-making organization. This is driven by us. You guys help develop this. You guys inform this. I talk to you all the time, and we make it better together. It's pretty exciting what it is. So however you collect data, as long as it's not on paper, although someday I feel like I have been asked, can you translate the sheaths of paper we have in our basement? I wish we could do that. But right now we accept data through API. And so I'm going to talk a little bit about the importance of our technology partners in this. Part of what FoRSE is about is, the main thing is about partnership. And the impact that we can make together, and that is not just providers, but our tech partners, our research partners. So however you collect data, we have a very easy, very simple way to push data to us, and not patient data. We don't get patient names. We don't get data that's going to endanger your program by submitting it. It's all de-identified data. Sure, we could do a lot more with patient data, but we can do a lot with de-identified data. And we rely on our tech partners to de-identify your data, push it to FoRSE, and we have this cloud, this FoRSE de-identified data repository. And what we do with that is we develop an annual report, which I'll be talking about, that summarizes the work we're all doing as a whole. And then we provide individual reports to every one of those people that raised your hand. If you're submitting data and you submitted data up before December 31st of last year, you'll get an individual report this year. And so far, we're not charging. At some point, I think we'll have services that are, hopefully next year, that we can charge for. But at this point, we've been doing everything, providing it at no cost. So providing back to providers a confidential report. This isn't something we're going to put on LinkedIn. This is the treatment center that has the best outcomes or the worst outcomes. This is for you. We give you a report on how you're doing relative to this large group of quality treatment providers that are doing the work together, and research evidence. And I'm going to talk at the end about why this is important, why the research evidence piece is so important. So this is where we are. We have 103 treatment providers. So that's 103 signed legal agreements to share de-identified data with FoRSE, and for us that we sign off that we will keep your data secure and confidential. We have over 300,000 patient episodes of care. That's a patient episode being from admission to discharge and beyond of any type of treatment, any type of, in fact, recovery support as well. Recovery supporters are starting to join FoRSE. Sober residences, recovery homes, recovery community centers, starting to be interested in joining this as well, which is really exciting. We have almost 1 million surveys. And if anyone asks, how do you measure outcomes? Well, we would probably all answer that question differently, but this is what most folks have been submitting. PHQ-9 is the number one, which is a little strange. PHQ-9 is a depression screen, but it's well validated, and it's in use, and it's free. And so are the GAD, the BAM, and the BARC. Are those the best measures? Honestly, we don't know. We don't have enough research to know what the best measure is. The blood pressure cuff that tells us how people are doing. We don't have a commonly accepted universal measure of recovery that everybody agrees on. And so we said, well, we'll take what you got. And that's where we're starting, because we have to start somewhere. So the FoRSE annual summary was just out a week or two ago. Has anyone read it? I've gotten a couple of questions, actually. I've had someone from Horizon, which is our newest FoRSE data site, emailed me a question. I don't think they're even here, but he pointed out a number and asked me about that number. And I was so excited because he said, can you explain this to me? I said, I certainly can. This is exactly what that means. And this is all the context around that number. These are the participating organizations across the country. If you represent a treatment center or recovery support provider in North Dakota or South Dakota or Wyoming or Nebraska, Iowa, come talk to me. We need you to be part of this as well. What's not on there is Crossroads Antigua. We are international. I know, yes. This is an international data program. You don't hear about that. We went through all the legal machinations, and thank you to Crossroads for supporting that process to get international data in. We now have data from across the world, and I'm hoping to add a few more as we go forward. And this slide that you can no longer read, which is wonderful, is everybody who's involved. If you're not on there, let's get you on there, because it is easy, particularly if you use one of our connected tech partners, which I'll show in a minute. But if you don't, we can get them connected and get you connected. Not everybody has been able to submit data yet, so what you cannot see is that those little stars next to some of them are the ones that are actively submitting data, and a few have gotten stars even in the past couple days. And so this is data that is coming into us as we speak. I want to take a minute and thank our tech partners. We did something different this year. We had a FoRSE room. We've had not great attendance at the tech partner demos because I think we squeezed them in at the last minute, and that was on me. But I got to meet, for example, in person again, Kristen and Laura, who are from Best Notes, who were one of the early EMRs that connected to us. Kipu, who sponsored the FoRSE room, they brought their developer. Is Phil in here? Phil? No, he's not in here. But they brought their developer, the guy that actually mapped some of our data points by hand because they believe in what we're doing. All of these folks, ERP Health is later today, Team Recovery is giving a demo later today. We're so grateful to Petrie Consulting for managing our database, to Vista, Sunwave, Sigmund, Lightning Step, Aliva. Without them, we wouldn't be able to do this. And I'm not getting paid to say their names. I'm saying it because these are electronic medical record companies and measurement-based care companies who believe in what FoRSE is doing and said, you know what, we're gonna let all our customers push their data to you, we're gonna de-identify it for them, and we're gonna push it to you and not charge them, and we're not gonna charge you. That's amazing, right? I mean, the kinds of stakeholders that we're bringing together, the fact that we're bringing the tech companies and the providers together to make these decisions together and talk about things like, what does discharge type mean in substance use disorder treatment? It means something a little different than at a hospital, because hospitals don't usually have a administrative discharge for fighting and bringing drugs in repeatedly. You know, it's different. We're in a different world, and we rely on these folks to make sense of data and make it meaningful and usable for their customers. So, like I said, are these the best data points? These are the ones we're starting with. We took about, 1,000 surveys and measures and said, let's just go down to what providers are telling us is important and that they're using, and what we can pull fairly easily from the electronic medical record, and what we believe are absolutely essential. Gender, sexual orientation has just been added, age at admission, race and ethnicity, substance use disorder diagnosis, these things. If we do not have these things, we can't look at health equity. It's been a struggle. I'll show you the demographic slide in a minute. It's been a struggle even to get those data, because pulling out gender, people code gender differently. And people code race and ethnicity differently, and it's changing. The Gender Harmony Project, is changing it and getting to best practices, and we're following that. But our understanding of gender, these social constructions, are hard to measure, and they're going to change, and so we have to change with that. The accepted measures. So the reason we have it set up like that is that's what we want to know. If we want to know, is treatment effective, we need to know three things: who are we treating, what services are we providing, and what outcomes are we observing, right? We have to know what's happening to different folks from different backgrounds, have different social determinants of health-related social needs, different services, dosage, treatment dosage. That's something Dr. Hayes talks a lot about. What is a dose of addiction treatment? Is it methadone? Is it Suboxone? Those are the easy ones, right? Those are doses. What about a dose of IOP? What about a dose of outpatient therapy? What about a dose of recovery support? What's that? What about a dose of recovery residence? These are questions that we have not answered yet, and we absolutely have to. And the outcomes. I've done this exercise before where I've said, let's talk about what outcome are we looking for from addiction treatment, and I get 1,000 answers, and so we pull it down. Do we want to see? Is Norm Hoffman in here? He'd say we want to see remission. We do want to see areas. We want to see remission. Thank you to Dr. Hoffman from the Cater study from the 80s, some of the earliest. Yes, thank you for science. Telling us, he's told me from the beginning, you need to get remission in there, and it's not, and we will get it in there. Right now, these are the ones we have: substance use, mental health symptoms, healthcare utilization. We know that's important to payers. Recovery capital, I'm going to talk about that in a minute. These are the things that we think are important. We know that payers often see costs as being important, which they are. That's a very important part, healthcare cost. But as providers, we mostly care about quality of life and how our patients are doing, and if they're recovering, and building that recovery capital that's so essential. You don't have to use all those measures. We're very flexible. As long as you use one, you can be part of FoRSE, you can submit data. We've recommended measurement schedules. We're finding out these are very important, as we'll see in a little bit. Response rate is very challenging. If you're in a residential or inpatient program, it's fairly easy to get a response from a patient, but if you're outpatient or you're in recovery support or recovery housing, or you're post-discharge, getting responses from people is very hard if we're relying on patient report, which is what we're very interested in. Using a recommended measurement schedule, we encourage this because those are the data that are easiest to pull and easiest to summarize, and that's what's represented in the report. So if you're not using those measurement schedules, then it's a little bit more challenging for us to capture that. Okay, so this is our data. This report is the data from these, so at the time we summarized data from 88 treatment programs. And what we have here on the left is the aggregate from years 2018 to 2022, and on the right is 2023. for both of these, but you can't really say there's any trends. So don't think of trends, because every year we have more treatment providers joining, and so their data are represented, so it's not really a trend. But what we're seeing here, if you notice anything strange about the demographics, gender, there's a lot of males and a lot of females identified. The numbers that are less than 1%, we are not capturing gender diversity. This is a problem we've been trying to solve. We try to solve it with all those tech partners. We're not capturing it, whether we're not asking the questions or we're not pulling it from the right place in the EMR. We absolutely have to know these things, or we can't look at differences in outcomes across genders, across race. We know we have a largely white sample in what's being submitted for race and ethnicity, but we also know that the percentage of Hispanic or Latinx folks in the country is not 3%, so we're not adequately capturing ethnicity data, and we need to do better. But this is how we get better. We talk about stuff like this. Employment status on the left, housing status on the right. This is primarily housed population. These are the patients that we're treating in our programs from this current report. Primary diagnosis, as perhaps expected, alcohol is the highest group there, with opiates second, and a large stimulant group. You know, I think that the sedatives are very low because, you know, there's another pulling problem. If you write benzodiazepine use disorder, have we mapped that? Thank you to those EMRs that have we mapped benzodiazepine to the FoRSE category of sedative, anxiolytic, hypnotic use disorder? If we don't, then we don't have that well represented. Payer type, so we're largely supported by private pay. We have a growing group of Medicaid and other public funded treatment, which is amazing. That's another reason we're a unicorn, is we have all different types of patients and all different types of payment structures in one data set. Medications, if anyone went to the medications session yesterday, they talked about, we have a large percentage of patients that don't get any medications, and that's something that we need to talk about as a field as we move forward, because medications, that's where a lot of the research is, and so when people talk about gold standards, they talk about medications, and we want to talk about all the other pieces of treatment as well. But discharge type, you know, when I first started in 2020, I had someone call me and say, what are the different, what's the AMA rate for different racial groups? And I said, we have no idea. If there's, I think, a couple years, SAMHSA reported race differences in services, and you can find this if you look really hard in national data, but that data is primarily public funding data, and you know, this is our programs. In 2023, our AMA rate was 16%. So this is where we start to talk about benchmarking, that when you get your individual report and you can start looking, is it apples and oranges a little bit, but we have a number now, we have numbers. And we're cleaning and getting better at reporting these numbers every day. Length of stay, what's the average length of stay in the different categories? I wonder if you would have guessed, average length of stay in residential is not 28 days, it's not 30 days, it's not 90 days, it's 22 days. That was over 5 years of data. I'm going through these fast because I want you to download the annual summary and find a data point and ask me, Annie, what does this mean? So I'm not going to spend a lot of time on this. But I do want to show you some outcomes because they're exciting. We want to talk about what happens to patients during treatment, which is progress monitoring, and what happens to patients after they leave us in post-discharge. So this is a more exciting slide than you may think. You know, did anyone hear Corey Vilsaint talk in our research update on Sunday in the FoRSE room? There were about 15 of you there. One, yes, thank you, Bill. So why is this interesting? The BARC-10 is a strengths-based measure. This is not pathology. This is the brief assessment of recovery capital, and this is in treatment. When they start at 42 over there, that's about the recovery capital people have when they have, say, an opiate use disorder and they're in an ER. That's where they're coming in to treatment with us. And when they leave, that number, the yellow number 54. So the cutoff, the clinical cutoff for predictability of long-term recovery is 47. As Dr. Vilsaint said, who is the first author on the BARC-10, she said, this shows that treatment is a recovery accelerant, a recovery accelerator. It accelerates recovery, the dramatic increase that we see in recovery capital in treatment. And then the fact, I'll show you post-discharge in a little bit, that it's retained in the first year, even though response rate is a challenge, and there's lots of challenges in the data, it's remarkable to see that we are building the capital that people need, the internal and external resources that people need to have long-term recovery. We are building that in treatment. The BAM, not everyone's favorite measure. A lot of people use the BAM. The BAM has some psychometric issues, but it still shows us what's going up is protective factors. What's going down is substance use, and substance-related risks are going down over treatment. This is our data. This is exciting to see that this is happening. The FoRSE Outcomes Survey is a kind of based loosely in a way on the national outcomes measures, the NAATP. It was developed with Nick Hayes, with Omni Institute helped us with this. Lots of support from John Kelly at Recovery Research Institute, looking at what is really important besides symptoms. And so there's things on the outcomes survey like what's your current employment status, and look at that over time. I should have worn my glasses, but you can see from in the first year of recovery going up to 77% employed. Lower response rate, as we know, but that's a bias, but that's exciting. And at the bottom, have you experienced a return to use or a relapse, however you refer to that, since discharging from treatment? Over 5 years of data, those numbers are, we didn't put the ends there, we should have put the ends on that graph, but to see that our rates of no are still very high through the first year of recovery. This is our data. That's what's, I just keep saying, it's real data. Yes, it has some issues. We need a lot of data validation here, but this is what we're seeing. The PHQ-9, so this is data from, look at that decrease from admission to discharge. The PHQ-9 cutoff, clinical cutoff for moderate to severe is at 10. People come in at, on average, 12 something. And when they leave, they're below that range. They're in the minimal to mild depression range, and they stay there. Same with the GAD, the Generalized Anxiety Disorder Scale. The cutoff there is 8. That goes from 11 down to 6, 5 at discharge. And this is across all programs, so this is just very global data. But this is what's happening in treatment. People are getting less depressed, they're getting less anxious, they're building recovery capital, they're decreasing their substance-related risks. These are dramatic changes, even in this massive data set that we have. And then this is my favorite slide. Nick calls this the spice. This is the spice in the graph, or in the report. Individuals who completed more than 30 days of treatment were 65% less likely to relapse compared to those that completed less than 30 days. We've known this for a long time, but we're seeing it in our data, and we have this represented in our own data, which is so exciting. Individuals observed to have high psychiatric acuity at admission. So those folks that had high PHQs and GADs at admission, they are different. We have to treat them differently because they're 60% more likely to discharge and to relapse and discharge prematurely from treatment compared to those with low admitting acuity. This is why we need co-occurring capable or co-occurring enhanced programs, because these patients are fundamentally different and need different services. And on average, a 42% decrease in symptoms of depression, 39% decrease in anxiety, and 51% decrease in symptoms of substance use disorders, not just use, but related risk factors during the course of treatment. This is Dr. Vilsaint, who I fangirl about a lot. She said, we have an opportunity to change the landscape of treatment evidence. So this is where I'm going to talk just for a moment here as I wind up about the power that we have here in this program. This is a researcher, this is a recovery scientist, and she's also a health equity specialist. And she's on the FoRSE board of directors. And she said, we've always looked at Medicaid data, that's what we've had. We've been able to look at Medicaid data and that's it. We can change the landscape of treatment evidence and look at what's happening in your programs. We have this new opportunity because of FoRSE. So next steps, we're going to keep validating the data. Encourage your vendors to complete the 2024 updates to the API. Yes, if they haven't, we need that to happen. You'll be getting your site-specific reports. We're hoping to complete those this summer for this year. Next year, we will have a live data dashboard that will be a fee-for-service option, and you'll be able to see your data all the time and not wait for an annual report. And then research studies. So I'll come back to that slide. Oh, this is a little bit old. I added a slide in there that's not in there. Okay. See, this is my problem. I do slides at midnight. But let me just tell you about this, our ability to pull together stakeholders. The 3 researchers we had on the first day on Sunday, we squeezed them in at the last minute. They each had half an hour. The first one was Dr. Sarah Matsuzaka. We have our first peer-reviewed publication, and that is, yeah, thank you. And you know what it's on? It's on the level of LGBTQ bias in addiction treatment providers. There has not been a peer-reviewed published study on that in 15 years. Can you believe that? And thank you all to some of you sent that email out to your staff because we had almost 300 respondents in that study. And that was FoRSE, that was NAATP, that was partnering with Montclair State University. And Dr. Matsuzaka said, you are providing an opportunity for researchers to, not just this data, but to connect researchers and providers in a way that has not happened before. Providers that take are primarily funded by insurance companies. We don't get insurance company data. We don't get to see that. They have it. We don't get to see it. But we get to do research now through these partnerships that show us things like that the levels of trans negativity and bi negativity are much higher than gay and lesbian negativity. We know that, and this is reflected in our society, but we get to see that in addiction treatment providers, that we still struggle with how do we treat people who are from the trans community and bisexual communities. Bisexual communities and trans communities have some of the highest rates overall of addiction. And we're struggling with bias, and we need to be looking at things like that. The second researcher I mentioned about the BARC, Corey Vilsaint, talking about the dramatic increases in recovery capital that are sustained through the first year of recovery in FoRSE data is so exciting. And the third one, Dr. Ilgen is back here, Mark Ilgen. I went to graduate school with him, go Buffs. And he talked about, we are on 2 grants with him, two large-scale grants. And he told me, you know what I want to do, Annie? I want to study what works in residential treatment, because that information is not out there as much as it needs to be. We want to look at interventions in residential treatment. What happens if we intervene on people for substance-related insomnia? What if we intervene on people for substance-related trauma symptoms? And what if we we introduce evidence-based interventions, and we pay treatment providers to offer this evidence-based treatment? We pay the treatment provider to do this. We help them do this. We facilitate this, and then we publish it. This is how we get noticed as an industry, right? And so we are on these grants, and if you're interested in those kinds of studies, talk to Dr. Ilgen in the back, talk to FoRSE. We're hoping that we can do more and more of this, that we will be taking what we do every day and introducing it into the research literature, introducing it when we do our next Hill Day. Mark Dunn is always asking me, he's our lobbyist in Washington, he says, Annie, give me some data. I want to take something to Congress and show them what we do and show them the transformations that are happening in our programs. So that is the power of FoRSE. So I encourage you to think about ways to support FoRSE. If you're a treatment program or a recovery support program, join us, become a data site. It's very easy to do. We could do it. You could be sending data next week, particularly if you're with one of our connected tech providers. Donate. I sold my first unicorn today to Zia Recovery. Thank you. She didn't have her phone to scan, so she said, I have $6. Can I have a unicorn? I said, you absolutely can. You know why? Because is Kristen here from Zia? She inspired the unicorn. She said, you're kind of a unicorn. You should make a unicorn. So we did. Donate. We are a nonprofit. We are a nonprofit for a reason. You can make a tax-deductible donation. We didn't get a lot of donations in the FoRSE room. The FoRSE room is brand new. We didn't get a lot, but we encourage you. We're now going to just give away our unicorns, our mugs. Don't put them in the dishwasher, we found out. But they're still high quality, very attractive mugs. And because we really want to always talk about health, equity, and inclusion, we have international candies, which are now free for you as you exit the room today. But we encourage you all, even if you come up to me, I am wearing a handy donate to FoRSE QR code. So you can just scan me and donate to FoRSE. Because we made ourselves nonprofit for a reason. We believe in what we're doing. This is NAATP's Recovery Research Foundation. You will continue to hear about this because we're going to continue to take the world by storm. We're going to continue to tell, as Kristen said from Best Notes, we're going to tell our patients' stories and data, and we're going to do this together. Connect us with others that you think are important for us to talk to, your research friends, your funding friends. Connect us, be part of us. And now I'm going to turn it over to Dr. Hayes to talk about how you can use data, not just in a national program like this, but in your own organizations to improve what you do every day. So thank you so much.
How's everybody doing? Experiencing a little trauma from graduate school, stats class? Hopefully not. We're going to start this morning with doing regressions by hand. No, I'm just kidding. Can we give Dr. Annie Peters, a round of applause? I'm blown away by your resilience, your work, your leadership. Annie, I'm talking to you. Don't look away. And all of you. All of the technology partners, all the sponsors, all the leaders in this room that have had something to do with creating FoRSE what it is today. I remember flying into Denver International Airport in 2019, not expecting the next year to turn out how it was. And our board chair at the time, John Driscoll, led a discussion amongst many of the folks in this room about could we do together. And I couldn't be more proud, really from the middle of my heart, that this trade organization stepped up to the plate with John's leadership, Bobby Ferguson's leadership, and many, many others to raise money, right? Put our kind of data where our mouth is, if you will, and create a program that can advocate for our services effectively into the future. And importantly, answer questions we don't even know to ask yet. I also just want to mention that there are predecessors here like Norm Hoffman and the Cater study and many others, and NAATP in particular, that have really paved the way to make this exciting today. And I really want to make sure that we thank them for dedicating. You never thought you'd see a researcher cry about data, but for dedicating their lives to trying to do this work so that we can tell our stories. Like Annie said, I really believe that our future ability to advocate for our programs will be undoubtedly grounded in data. Anecdotal story about personal recovery are very valuable and they have their audience. But if we want to empower Mark Dunn, sir, to do what he needs to do with our partners on Capitol Hill, if you will, to help us improve our programs and improve access, we need to continue to invest in what we're doing with FoRSE. So thanks to that. Today I wanted to talk a little bit about what it means to become a data-informed organization. Annie did such a great job highlighting our work as we put together this annual report for you all. I hope you have a chance to check that out, and please email her with any questions you might have. And feel free to join our annual stats camp. We kind of have a new tradition every spring. We meet in Nashville and we have a stats camp where we're crunching these numbers together. So I promise you it is a lot of fun, followed by tacos. But one thing that I really wanted to talk about is how our organizations can become prepared operationally to equip ourselves with the technology and information we need to make informed business decisions, right? So I've been at Cumberland Heights for almost 6 years. In fact, when I first interviewed at Cumberland Heights, I told Jay Crossan, my boss, that I needed to pray and ask my higher power for some guidance on that decision. And he said, well, I'd also like you to consider Jay's will in the matter. So here we are today. Thank you, my friend and boss and mentor in a lot of ways, for allowing us to improve care at Cumberland Heights and sort of fulfill some of my nerdy desires. I have no conflicts of interest or acknowledgments or disclosures to announce today. So what does it mean to be data informed, right? Importantly, not data dominated, but data informed, right? What does it mean as a provider to be able to make informed treatment decisions as a function of our patients and the programs that we support? Don't read the definition. In your own words, I'm asking for one brave soul.
What we're doing is really working.
Absolutely. Thank you, Ed. Shout out to Ed and Stillwaters. Appreciate that, brother. Yeah, is what we're doing working? You know, there are probably some providers in the room that struggle with being able to identify what is happening in their health system as a function of data across any given day. So how many calls are you receiving every day? Let's start there at top of funnel. How many opportunities are being created in your CRM, right? What's the length of engagement in your health ecosystem across all the programs and continuum of care that you offer? And then importantly, what outcomes are you observing? So what I'm saying is effective data and becoming a data-informed organization is not limited to research and outcomes. In fact, before you even get to that place, you need to make sure that you invest in the hardware, the software, the people, the processes, the culture that's able to support that, so you can take that, as my friend Randall Lee likes to say a lot, from soup to nuts. But really what it means is codifying your continuum. Codifying your continuum so you can support patients away from treatment failure and you can support more effective business intelligence. So for us, what are some real examples? What are some real examples of our journey that we've been on at Cumberland Heights over the last 6 years and beyond? Well, first, as Annie said, we like to describe what we do at Cumberland Heights along 3 domains. Who are our patients? That's one of the things that I love about FoRSE so much, is we made all these assumptions over the years that Cumberland Heights treats the same patients as does Ashley, right? As does Fellowship Hall, as does Karen. Is that grounded in our data? Is that grounded in reality? We're able to see that a little bit more. What treatments are we providing? Like Annie showed, the slide of data that showed length of engagement or length of stay as a function of level of care. I heard some murmuring behind me about being a little surprised of the variance, in particular related to residential treatment, right? So it's important that we're able to visualize that as an individual organization, and then what outcomes do we observe. There are many different internal process investigations that we're able to complete as a function of this. And I'm going to give you today the pragmatic tools. So we're going to take it out of our, my heady environment, and I'm going to give you some tools that you can consider as an organization for you to invest in these processes yourself. The first analysis I ever did at Cumberland Heights, does anybody want to take a guess at what that was? Not you, Jay. They say when you teach that you're supposed to wait a full 2 minutes. So the first analysis that we were interested in doing at Cumberland Heights was an exploration to understand how to prevent treatment failure, as Michael Lambert likes to call it, right? Better understand why people are AMAing or leaving treatment prematurely, right? It's a great question to ask as an organization, as any kind of provider. So fresh out of graduate school, as a quant scientist, shout out to my quant friend in the front row, I did all the things, got into SCM. I built this beautiful, you would have loved it. I built this beautiful auto-regressive cross-lag panel model. Who cares? It doesn't matter. But I did this thing because I met with all the stakeholders in the organization, and there were so many explanations as to why people AMA. You might sit in these very same leadership meetings. Well, it's when, it's the transition away from detox medication to non-medication. It's the weekend because we're not staffed up in particular like we are during the week. Well, it's because we serve corn dogs on Wednesday, whatever it might be, right? And we heard all these answers. So I built all these independent variables. We had over 50 different indicators of outcome in this model. And I was so proud and excited. And SPSS, I think at the time, this is before I fell in love with R. And anyways, I click execute. And do you know what the #1 predictor of AMA was at Cumberland Heights for the past 5 years at that time was? It wasn't the corn dogs. Yeah, we do serve. Why are we hating on corn dogs? I love corn dogs. Having previously AMA'd. So it was a really important orange light indicator for our clinical and medical teams to have a flag in our medical record dynamically. That's how we set it up afterwards, to help them better support individuals that might have a history of leaving treatment prematurely, which sort of makes sense, right? This is as I was starting to begin to learn how to invest more effectively in creating feedback loops in our electronic systems to help inform treatment outcome. And lastly, of course, valid outcomes. And I'm going to talk about another example in a moment about valid outcomes, in particular with payers. So as I get into some examples before I really talk about the scaffolding of a tech stack to do things differently, when I first started at Cumberland Heights, and Marvin, I'm going to keep looking at you, and you give me the 5 minutes when it's time to wrap up. I don't want to go over. But when I first started at Cumberland Heights and I was running that very same analysis, one thing, and you will all identify with this, I got with the director of IT. He's a great member of my team today. His name's Jimmy. You'll see him highlighted in this email, actually. And send me all the data we have from our CRM and our medical record, because those data sources didn't talk at the time and all of this. And so he sent me this big data file. And guess what? 70% of race and ethnicity in our medical record for our own patients were missing. 70%. And I went to Jay and he said, that's not surprising. We had many discussions about it, and we're proud to highlight the problems that we've really had in our ecosystem so that other people can learn from it. And so what we created, shout out to Mike Petrie, is what we call our gardening system within our health system. So we created a dynamic report so that our admissions teams, our clinical teams, and our medical teams would have information ready-made that, hey, this is a missing variable in the medical record. Can you please go garden it? Can you please go follow up with it? And we did some other training with our call center, because it turns out when we got with boots on the ground staff about why we weren't collecting race and ethnicity effectively at all, you know what they said? It's an uncomfortable question to ask. So that was a failure within the organization to effectively train those front-end staff to feel comfortable to ask that question, right? And I'm happy to report today, as a function of our gardening processes, we moved that from 70% missing to 0% missing, right? Another example, where's Jamie Vink? Is she in here? I thought she would in particular appreciate this. We had a Sentinel event last year. Again, I think we need to be more transparent when things happen in our organizations and we struggle and talk about how to improve our systems. We had a Sentinel event related to actually a previous patient's death. And it prompted us to take a look on how we monitor and codify suicide risk within our organization, which is very important. We use the Columbia CSSRS, and at the time we were in the mid-80s in terms of effective follow-up. Is everybody familiar with an SRA process and Joint Commission, and you need to follow up within a certain time period? I see the program directors nodding their heads, right? And how hard that can be, right? Especially if that CSSRS is on paper still. Or especially if you get with your medical record and they say, it really depends, we're gonna have to develop a solution. That's a common answer, right? So we took it in our ecosystem, and again, with gardening, we created a dynamic notification system where people were able to effectively follow up on time, and we moved that from 20% missed, right? If somebody's endorsing suicide risk as a function of that measure to 0%. That's a big deal, right? And this is not on paper. This was not born out of some large committee within our organization that depends because it's Tuesday because this person's not there, right? This is solely dependent on our technology systems and our processes in our organization. In other words, letting technology work for us instead of the other way around. You've probably heard your clinicians and other leaders in your organization talk about that. The documentation can be such a bear in our organizations. The processes of our systems can be such a bear. Last but not least, and I was talking to Marvin about this earlier, and I redacted this because this is a more recent example, but when you get to have some of the success we've had in our ecosystem as a function of data, sometimes you'll get payers, which is rare, just to be clear, but you'll get payers asking questions about, hey, can you help us? We're trying to better understand how two plans in our offerings differ, right? In other words, they're trying to understand why they're paying more for one group as a function of the other. Can we have this big meeting about it? So we put together this report, myself and Antoinette Gajinska, shout out to her and her work on FoRSE, by the way. And what was really interesting is you see the first table up above is splitting that data source for the patients that we served for that insurance company and across the two policies that they have and the customers that we served, and then readmission back into our health system, right? So you can see that as a function of 90 days, 6 months, and 1 year. Well, what we did in before that presentation is I baked in length of engagement as just a thought experiment with them in that meeting. And as you can see, really, I took that very same sample, I collapsed it together. Instead of by policy, I split it by length of engagement. And you can see there's a clear relationship between engagement or effective dosage and low readmission back into our programs. As providers, we need to have access, ready-made access to this information so that we can communicate these findings with payers, as an example, all the time. I guarantee your finance teams will be very grateful for it, right? But what I've learned working in this field and working with payers at Cumberland Heights is insurance companies are groups of people across departments that are big machines just like our programs are. And it really takes a collaborative effort to try to kind of move the needle there. They were blown away by this. They were kind of stunned by it. So what do I talk about? For the leaders in the room that are struggling with data interoperability, right? At Cumberland Heights, we call them the Big Five. So there are 5 applications that we use to do business, generally speaking, in the treatment field. You guys following me? One might be your phone system, one might be your CRM, one might be your medical record, one might be your payroll system, and one might be your HR system, right? And today, we usually buy those off the shelf. Right? Some cloud provider, it's a web-based application, we buy it and we start using it, correct? But what are the problems when you might have 5, in our case, 8 or 9 different systems that are living on 8 or 9 different cloud instances that you don't have access to? What are the problems? Silos. Yeah, those data don't talk to each other. When I started at Cumberland Heights, we actually had 1.5 FTEs dedicated to pivoting Excel tables by hand every month. I heard some grumbling, so that's a sign of identification, right? and it was just riddled with error. But that's because we were using the native reporting applications in those systems. We had to pull the data down and meld them together. So when you're considering trying to build for success in the future and how to become data informed, I would suggest that you start along these 5 components. How do you collect your data? How do you analyze your data? How do you integrate those data sources? And I'll give you an example of how we do it. By the way, no one owns algebra. I'll tell you everything. I'll tell you our vendors. I'll tell you how much we paid for it. I'll make introductions. We have nothing. We are interested, and I'm very proud of this, we are interested in the collective. There's more than enough people, as Annie said, Dr. Peters said, every 5 minutes someone experiences drug or alcohol poisoning or overdose. It's an important issue. Data governance and data culture. What are the culture that support these systems? We've learned a lot about that as well. So let's get out of sort of these heady examples and let's talk about like how we actually do it at Cumberland Heights. So on the left-hand side, those are your data inputs. Maybe that's your outcomes vendor, maybe that's your CRM, maybe that's your medical record, right? And there are people in your organization every day that are in there, right, putting in information, hopefully following the guidelines set forth by Data Validation Guidelines 2.0. Talked to Dr. Annie Peters about that. And where do those data go, right? So at Cumberland Heights, we've actually invested in a SQL environment, and I'm so, it's actually on the other, it's right next to my office. And so basically what that means is there's a server on at our headquarters, and we have the staff and the hardware to maintain API integrations directly with every application we use in our health system, inclusive of our phone system, inclusive of CallRail, inclusive of Google Analytics and Google Ads, right? And now it's kind of like Burger King. Everybody wants it their way at Cumberland Heights, and we struggle to keep up as we churn through data. But the middle of this visualization is really what's important, right? It's how these data sources come together, how they're wrangled, right? How it's cleaned. We call those the data plumbers at Cumberland Heights, and then what we do with that information. So we're all familiar with the last line of this slide: dashboarding, Power BI, Tableau, how to visualize information that we're collecting in our ecosystems, right? But that's really just the first step of any data analysis practice in your ecosystem, right? There's also descriptive analytics, right? How are you consuming and talking about in your health system? Who's coming to your programs? Is that information dynamic, automatic, and ready-made for your clinical, medical, finance leaders to really consider? Predictive analytics, how to forecast future outcomes and risk, and then prescriptive, which is where we're starting to flirt with a little bit at Cumberland Heights, which is recommending treatment dosage based on the sample size of data that we have available in our ecosystem, right? That's a big deal, right? Being able to tell somebody, hey, based on who you are descriptively, demographically, and your experience, we know that other folks that have those experiences had most success in our treatment center when they did X, Y, and Z. How valuable is that information? That doesn't guarantee success, but that's very, very valuable information to be able to share with families, other partners in the communities, and clients themselves. I was going to show a few of our dynamic dashboards. You can talk to me. Please schedule a meeting. Again, I'm happy to show you anything where, you know, at any given day, any minute of any day, you can consume information as a function of a lot of different domains at Cumberland Heights. I need to give a shout out to my QM people, any quality management people in the house. Oh, you left them at home. How dare y'all. Oh, we got one here. Just don't be shy. Come on, sister. We appreciate you. One of the departments that I get to manage at Cumberland Heights is quality management. And let me tell you something. Shout out to Annie again, because if you want to have a headache, ask every treatment center to standardize the way that they report discharge type, because quality people might have an opinion about that, right? Yeah. So thank you. Well, thank you for your support. We appreciate y'all. But data quality is really important. Privacy is really important. Cybersecurity is really important. When you start to invest in systems like this, how do you protect them? We all read recently in the news, Ascension, a very large healthcare provider in this country, just had and they're still, it's a scary situation for them. It doesn't seem like they might have a clear path forward. And then policies, how do you document what's actually happening in your organization? So things to consider, gosh, I gotta say, have an organizational champion. It's so important. When I started at Cumberland Heights, one of the issues that we had as an organization is all the different teams that were touching data. You probably can identify with this. You have technology, you have quality management, you have medical records as an example. This is before the Research Institute. It was bifurcated as a function of the budget organizationally and as a function of leadership team responsibilities. So there were different leadership team members that were managing each of those teams. Well, you can imagine as you're trying to forecast success in your organization year over year, it was really hard to help get everybody on the same page singing from the same hymnal, right? And some of those priorities across those different departments were clashing with one another. And it was a really big issue. I'll come back to that. Some of the problems to avoid that we've learned from is not to rush this process. I think what I wanted to say here, expect delays and stick to your simple goals. API commitments are a big deal. Once you create the roadway with an API, and we're always updating our API. We're always having to maintain the different APIs that we have created within our SQL environment in our organization. So that is an investment in the personnel that are needed to do that on a Tuesday when you did not expect a new patch to come through. But it is the cost of doing business if you want to be data informed. You can talk to Jay Crossan about that. And then staff shortcuts. What I've learned after hiring and moving on from several members of our team from a technology perspective is there truly is rarely an excuse to, quote, value engineer your technical staff. I mean, really, in this day and age, really all the way through, you're going to get what you pay for. So like I was mentioning, one of the things that we did is we collapsed the influence and the management and the leadership of all of our data-related departments under one sphere of influence. And what was interesting, actually, when I talked about pivoting manually, our Excel, our business intelligence that we report on every month, right? Who are our patients? Like, how many admissions did we have? How many opportunities do we create? What's the sex and gender of those individuals? Like, literally, that was all in Excel, all on paper every month. Now that's all in the cloud and dynamic. The first thing that we did is I sat down. There's sometimes nothing better than a piece of paper and a pencil, and sitting down with the CEO and sitting down with and just going down the line, sitting down with the CFO, the chief clinical officer, the executive directors of certain programs, staff boots on the ground that are consuming this information, and saying very simply, what is it that you care about? What is it that we need to effectively measure? Here's what I learned. Everybody were asking the same questions, but in 10 different ways. And so what we were able to do is slow the organization down long enough to say, hold on. First question, how many people are admitting into our programs over time? So we took a step back and said we need to pull out of our medical record 2 variables, time and admission ID, to be able to answer that question. And literally we tackled on paper every question that we needed to answer in business intelligence that way. There was no ChatGPT 4.0 way to tackle that, folks. You following me? It was stakeholder relationship by relationship, and there were mistakes that we made along the way, and folks that were upset because they felt like their needs weren't met before the needs of another person. And it was really important that we made ourselves available nearly 24/7 to make sure that we did this together. And to be frank, that I didn't make any assumptions about what other people needed. I dare say I learned a thing or two. So Jay will remind me of that. So what's this cost and what considerations do you need to make? When you consider hosting your own data and integrating your own data sources in your organization so that you can have rapid access to that information to make better informed treatment decisions for your clients and patients, and or make better business decisions as a function of marketing or whatever, what have you, are you going to host that in the cloud, or are you going to host that on premise? I can tell you why we made that decision. If we bought the server itself and the software that sits on the server itself on site, it was cheaper than hosting it on the cloud, because it doesn't really matter, but they charge you as a function of call to and from. And that's what we paid. I hope you remember that, Jay. That's the SQL environment, software instance, that's what it costs right underneath that. And then the technical staff, you know, the people that you need to protect this information and protect your organization, like a network administrator. This is the person that's in charge of your switching infrastructure and your cabling, cybersecurity, and any kind of serving infrastructure you might have. A developer and a senior developer that understands the back end and the front end of different applications that you use to do business. So not only can they plumb the data and get it to where you need to have it so that you can then send it to Annie, right? But also how to use it internally. What are the feedback loops that you're going to be creating within your organization so that Bobby can make an informed decision? Because there is information that when he gets into his office and he hits his space bar, this is the information that he needs to effectively lead his teams. So I thought it important to try to give a couple steps that any organization can start to participate in, and that's just accessing what are you currently doing? Do you have a CRM? You know, how are you billing for your information? Is that hosted on premise? Is that a third party? Do they have an API? Can you grab your data down? And I would really encourage you just to use a simple piece of paper to start documenting that. Just don't make it anything, just get curious, right? Charge your teams to start unpacking that. And I would encourage you to start at the top of your funnel and move through all the way to the inverse of that, which is known as the bow tie. And then develop a strategy like I talked about. It's taken us nearly 6 years to get to where we are. And by the way, we still have really big problems in our data systems. So it's not all sunshine and beautiful regression analyses that are happening every day. There are big problems that happen. But develop a strategy. What's most important for you to learn? And for us, it was, who are our patients? Getting really good at understanding and being able to visualize and consume information about who were our patients, what time were they arriving, how long did it take them to move through the admissions process, right? And making sure that all the demographic and descriptive information about them was cleaned. Because I got to tell you, once you start pulling raw data down from your medical record, you are going to you're going to have issues in data validity. And I'll say right now, you know, Cumberland Heights uses Sunwave for our CRM and our medical record, and shout out to them. I've been on the phone with them. Shout out to them. I've been on the phone with them. There's no perfect medical record. That's something I've learned. But shout out to them doing the hard work, even at midnight when the MAR goes down. You know what I'm saying? Maybe not. Invest in technology. I really believe this, especially for the programs that are small. You know, as Annie described, as Marvin described, I think it's really important that we continue to help each other grow and mature. And there's a lot of quality treatment. What was it, the short list? Shout out to John Curtis, the short list of programs that are in this country. We need to be equipped to have the information that we need to help lead our programs into the future. And it won't be a world absent of technology. Importantly, I don't think we need to be data dominated, but we need to be data informed. Train your staff, build data literacy across the organization. There's no quick fix for that. I don't have like an asynchronous training that I can provide you. That's just the commitment of our data teams to make sure that they slow down long enough. Let me tell you something. Go hang out with my IT team. It's like a real episode from Silicon Valley. You know what I mean? Sometimes they can get really grumpy about things that people are struggling with, and I encourage them to have a customer service mindset. Our data teams need to have the same thing, because there are folks that are not worried about variance and standard deviation. They're worried about helping somebody that wants to leave treatment today, and that's how it should be. And then monitor progress. Rarely review and iterate. So just to wrap up here and dare I say, I might ask for a question or two, although sometimes we'll get collaborative. The future in practice of addiction treatment, I believe, will be prescriptive and tailor-made. Like I was mentioning before, when you talk about prescriptive analytics, I think that our programs will get to the place, and I hope that FoRSE gets to the place one day where FoRSE can do this for us, right? Because of the maturity of the data set that they have, there might be a future application that can be built where, based on the data that's coming in all across the organization, we can outline the expected trajectory of a treatment dose for a person based on their unique experience. And it's just algebra. It's just code. I can't stress that enough. We are so close to being able to take that step in just a few years. I think that the use of measurement will continue to allow our programs and our professionals to monitor treatment completion based on valid tools, not opinion. And for us at Cumberland Heights, this helps us improve our programs, better inform our potential patients, clients, and their families, and communicate with external stakeholders. Like has been said many times at this conference, I'm just, being able to codify your continuum and speak to the different stakeholders in your community about what to expect and how treatment really impacts patients over time is absolutely the foundation of what we need to be, how we need to be talking about our programs in the future. And there you go, the future of addiction treatment lies within our data. So if I have any suggestion for you today, just start simple, start small, start with one application, prioritize key areas that make sense for your business, and scale up, right? I think that for as much beautiful work that we've done at FoRSE, and it is beautiful work, there really needs to be a call to action from all of our providers to continue to invest in these technologies. Thank you. Come on.